Good morning and welcome to the Suicide Prevention, Intervention, and Postvention webinar. As we get settled and members join, please take a moment to introduce yourself in the chat. Write your name, your title, the organization you represent, and if you wish, a sentence about how your organization is acknowledging Suicide Prevention Month. We will get started at 10:33. Um, if you would please go and put the poll up of what you are hoping to learn from the webinar, that would be wonderful, Lacey. Before we begin this very important webinar, I would like to provide a content warning. Please take care of yourself. Suicide is a very delicate topic. Emotions may rise to the surface. Many of us are loss survivors, attempt survivors, and people with lived experience. Please make taking care of yourself a priority during and after the presentation. If you or someone you know needs support, please call or text 988 to reach the Suicide and Crisis Lifeline. With that, I would like to introduce our State Superintendent of Public Instruction, Tony Thurmond.
Thank you, Carrie. Greetings, everyone. Thank you for being here. As you know, September is Suicide Awareness Month, and I'm grateful that you all would be joining this conversation with us today to find ways that we can support our 6 million students and young people wherever they are. It's always difficult to talk about these topics, but it is important that we do. We know that young people have experienced severe depression and anxiety in ways that has grown since the pandemic. And it's important that we have open conversations about how we care for our mental health, that we remove the stigma of talking about mental health. The reality is that many of us live with mental health needs and or know and love someone who does, and that we can treat and care and support someone with mental health needs. And so I'm grateful that in California, we have so many great resources to support young people who are working through a mental health need. And I want to remind anyone at any time, young person, adult, doesn't matter what county you live in, what your zip code is, anyone can call anytime, 24 hours a day, 7 days a week. You can text 988 or call 988 to be connected with someone who can help you to find a resource. And I just have to say, in California, where we have so many great resources, I'm proud. We have our Children's Youth Behavioral Health Initiative, a way to provide mental health supports to children between basically from birth to age 25. Our schools have been provided with upwards of $4 billion for community schools supports, wraparound supports to help young people who may have a need. We've worked to secure scholarships for anyone who wants to become a mental health clinician in our schools. We can provide a $20,000 scholarship to you if you want to become a teacher or a mental health clinician and you make a commitment to serve in our schools. And so I'm proud of what California has marshaled together in terms of resources, but we cannot stop there. While our students are resilient and we know that they will overcome the challenges that they face, we know that we've seen an increase in suicide rates for some groups, right, including African Americans and Latino students. We know that when it comes to forced outings and the mistreatment of LGBTQ plus youth, we see many youth, high percentage of LGBTQ plus youth, have considered or attempted suicide. And so that we know that we must do this work with urgency. As someone who has experienced the loss of a loved one to suicide, I can't tell you how important it is for us to do everything that we can to help as many families as we can. My heart breaks to any of the family members who are on today who experienced a loss by suicide. And I just hope that we can dedicate to their memory our efforts to help every one of our 6 million students and any young person anywhere in our state to make sure that they can get help, so they can be supported, so they can live a healthy and productive life. And so thank you for being here today, for all of the partners and the panelists who will be speaking about all the resources that have been convened on behalf of our students. And just a reminder as I close, that to anyone who needs to talk to someone who's struggling with any issue, that you can call or text 988, 24 hours a day, 7 days per week. Know that we love you and support you, and that we're here for you. And I'm grateful for all of you who've joined us for this conversation about Suicide Prevention Month. Thank you and enjoy the conversation.
Thank you very, very much. And, I always want to share because I think it's important, a personal side to it. Our SSPI created the whole child division, knowing that we cannot just look at one view of our students, we have to look at the whole child. So I'm very honored to work on these initiatives. With that said, may I please invite Director Robinson, our director of our whole child division, to go ahead and come on camera.
Thank you so much, Dr. Sequeira. Good morning to everyone, and thank you for joining again today's Suicide Prevention and Awareness webinar. I'm Dominic Robinson, Director of the Whole Child Division, and it's an honor to welcome you again on behalf of the Whole Child Division and the California Department of Education. I also want to recognize and thank our State Superintendent of Public Instruction, Tony Thurmond, for his unwavering leadership in prioritizing student mental health across California. His commitment to fostering safe and supportive environments in our schools is truly inspiring. As we observe Suicide Prevention Month, I want to acknowledge the tremendous efforts of the Office of School-Based Health Programs, led by Dr. Carrie Sequeira, for organizing this critically important event. Your dedication to ensuring the health and wellness of California students is invaluable. I also want to extend my heartfelt thanks to all of our presenters and partners for their commitment to raising awareness, sharing resources, and engaging in this vital conversation. We know the work you do every day is changing lives, and I'm grateful for the collaboration of everyone involved. Suicide prevention is a shared responsibility, and together we are fostering a culture where mental health is prioritized, and no one feels alone in their struggles. As we move forward today, I encourage each of you to remain present, take care of yourselves, and continue supporting one another as we address these challenges with compassion and hope. And with that, thank you so much, and let's get started.
I appreciate the kind words. So let's move forward. So welcome. My name is Carrie Sequeira, and I am the administrator with the Office of School-Based Health Programs under the Whole Child Division. I'm very happy to see so many LEAs and COEs present here today to learn and support our students as we acknowledge Suicide Prevention Month, raise awareness about suicide prevention, and share messages of hope. Our objectives today include knowing the warning signs of a student experiencing a mental health crisis, learning about the suicide prevention model protocol and post-vention response to a death by suicide, hearing from an LEA in our state that has implemented supports for students' mental health. A panel of statewide experts will respond to the questions that you all submitted when you registered for the webinar, and learning about the statewide data on self-harm and death by suicide. At the completion of our time together today, we will conduct a survey and have a better understanding of the current reality and needs of our LEAs. There will be an opportunity for you to ask questions throughout the webinar utilizing the Q&A feature found at the bottom of your Zoom screen or Zoom platform, sorry. If needing language support, there is the ability to enable closed captioning at the bottom of your screen using the toolbar. And finally, we know that suicide prevention work is not dedicated to just one month of the year, but instead we need it to be embedded into the fabric of our school communities and break down the stigma around discussing mental health. I want to let you know that we see you, and we know that you are the front line with our students to assess and support the school communities in ensuring the mental, physical, and social emotional health of our 6 million students in California. And your work is greatly appreciated. So I would now like to introduce Dr. Tully. I had the pleasure of meeting Dr. Tully recently, and she is the VP of Clinical Integrations and Partnerships, Soluna. They are a Harvard-trained licensed clinical, they are a Harvard-trained licensed clinical psychologist and cognitive neuroscientist. Dr. Tully is a nationally recognized expert with 17 years of experience in designing, implementing, and evaluating digital mental health products for adolescents and young adults experiencing serious mental illness. Dr. Tully, would you join me?
Thank you, Dr. Sequeira, for the very kind introduction, and thank you for everyone's kind words this morning. I'm going to spend just a couple minutes talking about risk factors and warning signs and ways you can determine the level of risk that the young people you're working with might be experiencing. And I just want to start this conversation off by echoing the points about taking care of ourselves. I am an individual with lived experience of suicidal ideation myself. I have members of my family who have experienced this throughout their lives, and there have been some suicidal behaviors there as well. This is something that's really close to me, and I know that it's close to others. And so, as is almost always the case when we're talking about clinical things, it's not about something else, it's about us. And so as I talk through these risk factors and these warning signs, you might notice ones that are true for you or that are true for your loved ones. And hopefully today we'll come out at the end of this discussion feeling more confident that we're able to talk about this with each other, because the bottom line is that talking about it reduces the risk. So I think it's important to start when we try to understand risk factors by distinguishing between kind of long-term acute risk factors and then warning signs, and understanding what are the things that we can change, what helps us understand why a person might be at risk, and what are the things that we might be able to address to reduce that risk. So these long-term risk factors, they're typically things we're not able to change, right? These are lifetime general characteristics or ongoing factors that are there in the individual's background that the individual or us really have no ability to go back in time and shift. So it might be things like childhood trauma, early loss, family history of suicidal behaviors, chronic physical or psychiatric illness, as well as prior suicidal ideation and behavior for that individual. So often these are things in your history, in your background, that just elevate your risk, but we can't change them. Then our short-term risk factors, these are recent stressful events or perhaps exacerbations of existing stresses that we have in our lives that just kind of elevate our vulnerability, just makes that risk just get closer to the surface for us. So this might be a stressful life event. It could be a loss, a personal loss, a job loss, some social event that has created a lot of stress, financial stress, those things, as well as family conflict or a break in family support, separation, family separations, things like that, substance use, and then I think importantly, having access to means. So, we know that gun ownership and access is increasing over time, and we know that young people have increasing access to those. So it is a short-term risk factor that is important to be aware of for the young people we're working with. And we know that under the sort of stressful life event category, that the young folk we're working with right now are really concerned about things. They are more than 2/3 of young people are worried about the nation's future. About 60% of individuals aged 16 to 25 are concerned about climate change. These are worries and stresses that are sort of chronic in the background for young people. And then when big events happen, that stress level goes up. It's worth being aware of. The short-term risk factors, some of them may be addressable through treatment, so getting access to psychological support and social supports to address some of those risk factors, address some of those social determinants. But they're more malleable than your long-term, but they are less malleable than your warning signs. So getting really good at spotting the warning signs is probably where we want to dedicate our efforts. So warning signs are events, behaviors, emotions, or feelings that might precede increased risk for a particular individual. And the timing is it's really close to the event. So it could be minutes or hours before a suicidal ideation or suicidal behavior pops up for a person. And this might be increased substance use. It could be, engaging in impulsive or reckless behavior that has some negative consequence and then leads to dysregulation. We might also see a young person isolating or withdrawing or feeling extremely lonely. A young person might express hopelessness. These are all warning signs. And actually, if we go to the next slide, I break these out into more detail. So they differ from person to person, and an individual level assessment is really key. So I like to split it up in things they might do, things they might feel, things they might say. So we might see a young person, as I said, increase their substance use. They might start acting recklessly, different from usual. They might start to isolate and withdraw from activities they were previously engaged in. They might start talking about changes in their sleep or their appetite or their energy level. They might start saying goodbye to loved ones, either directly or in this sort of subtle way. They might start giving away possessions that they won't be taking with them. These are things that family members and close friends will often see. Things they might feel. So they might start talking about feeling increased depression, despair, loneliness, and isolation. They might start feeling a sort of loss of interest in things, a kind of flatness. It's called anhedonia, without joy, without pleasure in things that they used to enjoy. They might start having experiences of rage or irritability or feeling kind of physically agitated, like they can't sit still or they can't get comfortable. They might express saying they're feeling ashamed or humiliated or socially rejected, and they might start talking about experiencing heightened anxiety, particularly around social connectedness. And in things that a young person might say if they're at risk, they might say directly, I want to die or I want to kill myself. They might start talking about how they don't really have a reason to live or no purpose in life. They might talk about feeling trapped or that they just can't do this anymore is a really common phrase. I can't do this anymore. I can't handle this anymore. I just want to check out. And expressing feelings of like hopelessness or despair, or like nothing is going to get better. So you'll notice that there's some really key themes in here, right? There's themes of depression and negative mood, and there's themes of sort of, so internalizing themes, and then there's some themes of externalizing, right? So engaging in impulsive or dangerous behaviors. And this will be a change, right? So if you're noticing a shift for a young person in any one of these areas, then our ears should prick up, and we should probably do some sort of assessment. So if we go to the next slide, the National Society for the Prevention of Teen Suicide has a really nice fact sheet about this. That's a tip for, how do you talk to teens about it? And they have this acronym FACTS of how you might identify those warning signs and kind of a way to remember it. So feelings, actions, changes, threats, and situations. I've sent this out to our organizers and they can send it out with the meeting materials. It's a nice little sheet to think about when talking about with young people. Let's go to our next slide. If you are in a position in your job or your community where you have the opportunity to have follow-up discussions with people to evaluate risk, it's important to determine the severity of that risk, to figure out what are you going to do next. So it's actually quite common for people to have suicidal ideation without acting on it. And it's also quite common for people to engage in suicidal behaviors without having ideation. And so it's sort of an impulsive thing. So it's important to understand the distinction between thinking about it, having intent to follow through on those thoughts, planning how you might do that, and then actually engaging in the behavior. Those are kind of four really key parts of risk. So, is the person thinking about behavior? How often are those thoughts occurring, and are they controllable? So a person who has thought about it once in the last 3 months versus a person who's thinking about it every day obviously have different risk levels. A person who has a really hard time controlling or coping or ignoring those thoughts versus someone who kind of watches it float by, is at higher risk. So at a time in my life, these thoughts were happening a lot and I couldn't really control them and it was really distressing and I was at higher risk. At a time in my life later on, they're happening, but I sort of just watch them float by or listen to them as if there's a radio station on in the background. So the risk is lower. So I think those are ways to kind of find out what's the experience of those thoughts that person is having. I want to reassure you that talking about them with the young person does not increase the risk of something happening. In fact, it reduces it. So sometimes we feel nervous talking about this topic, and I just want to empower you that talking and listening and validating is going to reduce that risk. Asking about intent, very helpful on a scale from 1 to 10 or 0 to 10. What's your intention to actually act on these thoughts that you're having? Obviously, a higher intention is a higher risk. If they've put together a plan, what are the details of that plan? Do they have access to the means for that plan? How lethal is that plan? And what's their commitment to engaging in it? What's the likelihood that they're going to do it? Again, more details, access to means equals higher risk. And of course, very clear action there is to remove those means and put that individual in a safe place. And then finally, are they engaging in any behavior? So are they in the process or have they in the past? What are they, how are they doing that? And are substances involved? I want to just say one last thing when you're thinking about, is this suicide risk or not? A really helpful distinction between non-suicidal behavior and suicidal behavior is the intent behind it. So does the person intend to engage in this behavior in order to end their life? Or are they intending to engage in this behavior for some other reason, like emotion regulation, which is very common for folks who engage in other forms of self-harm? Having that distinction can just help you understand the risk that you're dealing with. So asking, what is it that this is going to give you? Like, what's the outcome that you're looking for when engaging with this behavior? Is it to help you feel better? Is it to ask for support? Or is it to end your life? And the answer that the person gives you will help you gauge where that risk is at. These conversations are not easy, but they are important. And if you're a person who hasn't yet had the opportunity to kind of practice how to have this sort of conversation, I encourage you to work with the folks in your community or in your colleagues to kind of practice having them so that when the time comes, you feel more confident that you're able to ask the questions to get the information that you need. I know we're going to talk more about this probably during the panel discussion, so I'll stop there and hand over to my colleagues. But I have plenty more thoughts if we want to talk more about how do we evaluate risk and make choices about what to do next.
Thank you, Dr. Tully, for all of that important information about looking for signs and the acronym FACTS. That's going to be very helpful to our audience. And just to let everybody know, we've received questions about slides and recordings. The webinar is being recorded and slides will be available shortly after the webinar. So I'd like to move on and introduce our next guest. I've had the pleasure of meeting her and her team in San Diego. I would like to introduce Heather Nomura. She's from the San Diego County Office of Education. She is the coordinator for Student Wellness and School Culture Department, Student Services and Programs Division at the San Diego County Office of Education. And she's going to share with you an incredible resource. She's going to share their policy to practice, the suicide prevention model, protocol, and toolkit. Thank you, Heather. And the audience is all ready for you.
Okay, thank you, Mary Beth. I'm happy to be here. Okay, so our County Office of Education, we're big believers in, we support all students beyond San Diego zip codes. And so really excited to be able to share this award-winning toolkit that we created and have really intentionally shared across the state with all COEs and CDE and all of our partners. So if we can go to the next slide, please. All right, so really in working with we have 43 districts, 129 charter schools in San Diego County, and often we, over the years, have received multiple requests around, there's so much out there, and just give me what I need to be able to do comprehensive suicide intervention. And so we were able to put together a very easy to navigate toolkit that includes everything from suicide risk screening, protocol, action planning, safety and wellness tools, a reentry plan, and information and resources. All right, next slide, please. So the policy to practice toolkit, it really is formed around the evidence-based Columbia Suicide Severity Rating Scale. And it is used because it is pretty much universally shared in many of our counties, definitely in our county with our cross-sector partners who work with youth. And it is the most widely used suicide risk screening tool for schools, although many don't use it, but the ones that do, we found that they were using it. So this really gets everybody shared language, shared way of measuring severity across our county. It also really helps develop our enhanced suicide intervention protocols to ensure our students are safe and supported. So I'm going to walk you through the toolkit and you'll see there are protocols that can, a best practice protocol that can be modified and adopted to meet the unique needs of each LEA. And then really using systemic best practice actions, templates, strategies, resources, that really is a holistic approach, a trauma-sensitive approach to suicide intervention. And proud to say we were the winner of the 2023 CSBA Golden Bell Award last year for the toolkit. And this toolkit has been vetted across the state with many of the suicide prevention experts here at this webinar, along with Columbia University and the experts who created the CSSRS tool and so forth. I guess next slide. And I think am I sharing my screen or are we gonna keep going? I'm fine either way. If you click on access the toolkit, we can show people, I'll walk them through the toolkit.
Actually, Heather, why don't you go ahead and take the screen, if you
take
don't
the
mind.
screen.
Yeah, that'd be great. Thanks.
Okay, let's see. Close. Here we go. Okay, and the toolkit should be opening up for you all to see. Okay, is everybody seeing the toolkit? Yes, we're good. Okay, thank you. I can't see you. I can't see you all. Okay, so this toolkit is really meant to be short. There's a lot of toolkits out there, and what we heard from districts is we are busy. We do not have the time to research, to vet, to go through all of the resources that are out there. So this was really meant to be a hands-on, grab, easily walk through the toolkit and see what is needed for comprehensive suicide intervention. So you can see here, it's a short toolkit and it's intentionally made that way. And, you know, the feedback was, we don't want to read about background philosophy, just give us what we need. And so that's really what this is intended to do. So again, the toolkit really is surrounded around the Columbia Suicide Severity Rating Scale. It is a suicide risk screening tool that in our county is most widely used now. And so everything that an LEA would need, from the brochure for educators, the free 30-minute online training that they can take. If they decide that they want to use the suicide risk assessment tool after using the screening tool where it indicates it's moderate to high, they can tap into that here. And then they also can take the training, online training from Columbia, which is about an hour on using the suicide risk assessment tool. So everything is here. The Spanish version, they more recently came out with an elementary version, so that's easily there as well. Everything on the toolkit is a screenshot of what that form or tool template looks like. Then you can see the Columbia is color-coded yellow, orange, red. The toolkit is aligned with the color coding based on severity level, whether it's low risk, moderate to high, or extreme risk. So here you see a template action plan for really having protocols for LEAs in place. And so starting from if it's a peer concern, a self-referral, a parent caregiver, or a staff concern, it's kind of best practice protocols. And this is really meant to complement the policies and protocols and practices that are already in place in LEAs, not trying to replace it. And therefore, they can click on these templates, open it up, and they are modifiable, if that's a word. And so a district can put their logo, they can change the information within here to make sure it meets the unique needs of that district or charter school. So the chart here is a template, and then the last color-coded piece is the action planning. So based on the severity level, again, with the color coding, the action plan gives you best practice steps that are needed to take based on the severity level. And when you open up the action plan, you're able to click on any tools or resources that are referred to in the toolkit, so you have it right there in the action plan. Again, this can be modified for each LEA to be able to fit the needs of what they have in place. We were very we were very mindful of making sure that parents and caregivers have the same information that school folks do. And often it is a district or charter struggling to say, what is the right resource to share with a parent, and what level do we share with the parents? So here we have first a parent acknowledgement form. So it's just a template when we want to make sure when there is a suicide risk screening done or an assessment that parents are notified. So it's a template to be able to do that. And then we have our vetted resources for information for parents. So the suicide prevention resource for parents brochure in English and Spanish, tips for parents and educators, just kind of one page. Suicide thinking and threats, helping handout for home. So all the work we do in the school setting to make sure students are safe and supported, these are tools for parents to have in the home to do the same. And then there's the Mean Safety, which is a fabulous website that really breaks down how to have mean safety within the home. And so that website is shared there for parents. And I'm not opening these up because I don't have enough time, otherwise I would, but I invite everyone to really explore this on their own. And then there's the student safety plan. So the most commonly one used is the Stanley Brown, which has all of the key pieces that are needed for students to be able to do this with students, to create that web of support. Who are their go-to people? What are their self-care practices? And then this is another one that's from Social Work Tech Safety Plan. It uses more contemporary language, and Stan and I both really like this one because it does highlight the reasons for living, which is really known to be best practice that should be included in a safety plan. And then this is really a key piece here. What we find, and I'm sure you all have experienced this as well, is that there is just a disconnect between the medical sector and the education sector when it comes to communicating when a student has been hospitalized or has been in crisis care for suicide ideation or a mental health crisis. And too often the student re-enters the school community and nobody knows, and it's business as usual. And so being very intentional about how we can create a re-entry plan where a student is able to re-enter the school community surrounded with supports. And this re-entry plan is not only including who should be at a re-entry school meeting, but it also gives ideas around how we can make accommodation for students, for assignments, for a classroom, for testing, and so forth. So really helps guide the school team, the parent, and the student to be able to build a plan that kind of really meets their needs where they're at. And so this reentry plan, I've heard just so much feedback about it. I've even heard schools use it for chronic absenteeism, and how do we bring the student back into the school community to make sure they're supported. And then this is where we really get into the trauma-sensitive approach to suicide intervention. So many of you might have heard of Handle with Care, where it's a trauma-informed approach when law enforcement is involved in the home and their school-age children, that there is a high-level anonymous notification to the school. similar approach here. So a student has been out of the school community due to suicide ideation or attempt. So bringing them back into the school community, sending this high-level notification to the school, to the teacher, that the student is going through a challenging, traumatic time. Handle with care. No details are shared. No other information is shared. And it breaks down. How do you handle with care? Just show extra love and compassion. Maybe you're letting them go lie down in the nurse's office to take a break that day. Maybe you are making sure that they are able to skip that exam that day and reschedule it. So along with that are trauma-informed, trauma-sensitive classrooms, how to create a trauma-sensitive culture. And really, this is kind of a best practice for all. So these are shared. And then we have a student self-care plan. And so this is an optional tool to be able to work with a student to really think about mind, body, soul, and to find the balance in everything and create a self-care plan that kind of has those three components in it. And we provide a sample one from a student here to give them an idea. And this is different from that safety plan where this is really, how are they going to take care of themselves on a day-to-day basis? What are they going to do to balance all that? And then we all know that everything we do in school communities is about building relationships with students. And we have great initiatives in our school communities. We have MTSS, we have PBIS, we have community schools. We have all these initiatives, but when you look at all of them, they all go back to one common denominator, and it's caring relationships. So we know that students need to have caring adult relationships to be able to thrive and succeed. And so this is a relationship mapping tool, and being able to work with students, and we do this with the safety plan, help them identify who are their go-to people that they trust, that they really feel care about them. So similarly, we're relationship mapping, who in their school, who in their home, who in their neighborhood are the caring people, maybe peers as well, not just adults, that they can put into their web of support and kind of reach out when they need that, hey, just need someone to, go take a walk with, or go hiking with, or whatever it might be. So this is another great tool. And then our county office every year does a teen guide to mental health and wellness. And every year we do it with students across the state. Shout out to Mind Out Loud and shout out to Bring Change to Mind. We work with statewide youth to really make sure that teens have what they need to be able to support themselves, their peers, and their friends. So it has the warm lines, the hot lines, ways to increase their own mental health literacy to support themselves and their peers. And then we have for the elementary parents, a young person's guide. Oops, that's my timer. So those are available as well. Our virtual wellness center was created for all students, all parents, all staff to be able to really tap into calming activities to kind of reset and go back to work or school. And then the last page is really just our link to many other different kinds of guides that we have to be able to support schools and districts in meeting the legislative requirements of different legislation around suicide prevention. What are you seeing right now? Am I still?
We see your the first slide.
Okay, so I want to make sure you see the feedback from the field. You're not seeing that?
No, we have the first slide. That's the overview of the toolkit.
Okay, so are you seeing it now? Sorry.
Perfect.
Okay, so lastly, I just want to share, I'm talking about the toolkit, how it's been.
Heather, sorry to interrupt. We are seeing it, but it's not in full screen.
It's not in full screen. Okay. I'm gonna get it in full screen right now. Sorry about that. Okay, seeing it now in full screen?
Yes.
Thank you, Stan. Okay, so feedback from the field. We have, with our MHSSA grant over the past couple years, we have really implemented this full toolkit into 430 schools. And so we are all about data, collecting feedback, and just wanted to highlight some of the many, many quotes that are out there. How has this toolkit impacted them? And, getting all staff on the same page to ensure consistent practices are in place, increased their comfort level, confidence, and capability in talking with students about suicide, which is a big one because it's never a comfortable situation, but be able to increase comfort level is one of the most important aspects in providing training and support to our schools. And then really being able to increase communication among all the different stakeholders that are working with students, better serving students by having a comprehensive plan in place, and then results in parents receiving appropriate communication and information. One quote I did not include, but there were many quotes about they would never have had a reentry meeting or plan if they didn't have this toolkit to give the tools to be able to have those reentry meetings and plans. So just wanted to share some of that feedback, and feel free to reach out anytime. Happy to answer any questions or share any further resources that are needed. Thank you.
Thank you so much, Heather. And I encourage our audience to go to San Diego County Office of Ed's website. Heather was able to touch on just a few of the incredible resources they have, but it's very robust. So the link is in the chat, and it will also be in the slide. So thank you again, Heather. Next up, I would like to introduce Stan Collin. Stan is the Director of Youth Creating Change, formerly known as Directing Change. Stan has worked in suicide prevention field for more than 2 decades since losing a friend to suicide in high school. He utilizes his experience to support and develop strategies to create systems-level change around suicide prevention. Stan is the co-founder of Youth Creating Change and a member of California Department of Education's Students' Mental Health Policy Work Group. Stan's going to share Youth Creating Change, which you'll see it captures student voice, and will also share some strategies and resources for postvention. Thanks, Stan.
Thank you so much. Just a thumbs up or something if you can hear me, see me. Thanks, Heather. Or maybe that wasn't a thumbs up that you can hear me, but hopefully it is. Hello, everyone. Thanks to the other Heather. So as we're switching into postvention, I just want to take a moment, take a breath, if that's all right. And it was mentioned that I lost a friend to suicide when I was in high school, and so I've been part of that experience from the youth perspective of sitting next to my best friend's empty desk and questioning what I could have done and what I could have said. And I think when it comes to, having worked in this field now for 25 years, I think anytime we talk about suicide, it raises our emotions and our anxiety. And we're so worried about getting things wrong sometimes that we forget how qualified we are. And when I lost my friend to suicide, I thought that suicide was about wanting to die. And therefore, suicide prevention must be about convincing people not to die. And it wasn't until I went through my own struggles that I finally realized that suicide is not about wanting to die, it's about not wanting to live. And while that sounds like the same thing, there's actually a huge chasm between the two. But that also means that suicide prevention is not about convincing people not to die. It's about helping people find their reasons for living. It is about, in my opinion, you can go and read all the research and all the theories and all the evidence-based practices. But ultimately, suicide prevention, or suicide, I guess, specifically, if you simplify it down, it comes down to 2 things: pain and hope. And suicide happens when pain outweighs hope. So I hope, you're going to walk away with more informed about resources and more educated today. But what I really hope you're going to walk away with is at least a start in the process of feeling more comfortable, to realize that you are way more qualified to engage in suicide prevention, intervention, and postvention than maybe you think you are. And to also acknowledge that if suicide prevention or suicide is not about wanting to die, it's about wanting to end pain, then maybe suicide really isn't the problem. And what I mean by that is that for the individual experiencing those thoughts, and QPR, Question, Persuade, Refer, talks about this, that people who are experiencing thoughts of suicide, suicide is not their problem. Suicide is what they mistakenly believe is the solution to their problem, but their actual problem is ending the pain. And so I think in the course of our work in this field, a lot of times we get so distracted by suicide that we forget that what we're trying to address is someone, especially a youth, who's in intense emotional pain. And so it starts with understanding that pain and soothing that pain, and then trying to inject some hope that that pain might ease and that maybe there's something past this. So I just want to start with that. And as we move forward onto the next slide, so I mentioned I'm from Youth Creating Change. Hopefully all or most of you are familiar with Youth Creating Change or the Directing Change Film Contest. But on the next slide, I just want to share with you a short film that was created by youth as part of the Directing Change program that talks about their experience. So I'm going to go ahead and mute, and if we could play that film, it's just 60 seconds.
This is how it could have been. Somber walks in the park, our minds crawling with your memory. Our hearts all feeling so heavy without you. I know you didn't realize that we all cared about you then, but luckily we saw the signs. You becoming withdrawn from school. I noticed you weren't eating or sleeping or even looking like yourself. So I reached out. I told you how loved you are by so many people and how devastated we all would be
Sorry, everybody. I promise we practiced this 10 times in the dress rehearsal.
without you. We don't want to look at an empty seat where you're supposed to be. We always want the best for you and for you to know how important you are to each of us. You still have so many places to see, so many people to meet, so many goals to accomplish. I am so happy to say that now you'll be able to.
If you or anybody you know are suffering from suicidal thoughts, please call the National Suicide Prevention Hotline at 1-800-273-8255.
And I'll drop the link in the chat to the video, if that's all right, so that you can watch it. I apologize for the tech issues, but we'll go ahead and I'll drop it to everybody, actually, really quick. And that's just one of over, we've been doing Directing Change now for 12, I think, years. So there's literally, I think, over 10,000 films on our website that you can access, download for free. I always use them when I'm doing parent training, staff trainings, just to have everybody take a breath and just remember that we're here to address what we're actually here to talk about. So anyways, apologies for the tech issues, but if we could move on to the next slide, I'm here to talk about postvention. So we'll go ahead and keep doing that. So part of the education code, you know, based on 2246 and 1767 is really what a lot of people don't realize is that California was unique in that many other states just focused on, we need to train our staff. We need to train our educators. And I actually appreciate what we did here in our state, which is we need to have comprehensive policies that include prevention and intervention, which you've heard about, but also really with an emphasis in postvention. And I know, especially right at this moment, many of you and many of our communities are dealing with that response to a suicide death. Sometimes on a smaller scale, but you know, some unfortunately have been very, very high profile. But just to really push the notion to our school boards and our PTAs and our administrations and across our teams that no, postvention is prevention. Postvention is intervention. It's a circle. It's not this line that goes from one to the other. And we need to not just think about postvention when a crisis occurs. We really need to think about it ahead of time. So on the next slide, I want to share with you some of my top resources. The Hurt Alliance has done tremendous work. They're out of the Palo Alto community. As many of you know, they experienced a ton of a lot of tragedies a few years back. And what I love about their toolkit is that it didn't recreate the wheel. What they did is they they really focused on being more of a clearinghouse. Like they went and they looked at what is the best of in prevention and intervention and postvention. And they have a downloadable PDF, but they also have a really good interactive website with some kind of edited versions to make things just a little bit better or a little bit more school appropriate. Now, anybody out there who's just putting their, their toe in the pool of suicide prevention in the school setting, I would encourage you to start with the SAMHSA toolkit that you see on the bottom right, the Preventing Suicide, a toolkit for schools. It really takes you from A to Z, and it's a little bit dated as far as when it came out, but it's still really, it's so high level that it really focuses on what does comprehensive suicide prevention look like in the school setting. It's not just about coming in and talking to kids about warning signs or educating staff on protocols. It's really what do we do in a comprehensive setting. Now, specific to postvention, the After Suicide Toolkit from AFSP, the American Foundation for Suicide Prevention. If you have nothing else in your pocket when a suicide death does occur in your school community, and not just of a student, but a staff member here, that is a place that you can go and very easily navigate what are the resources you need. And then for those of you who are really passionate or want to geek out on this topic like I do, the Suicide in Schools, they just came out with their second edition. It is the best book that has ever been written on the topic of school-based suicide prevention. It focuses on prevention, intervention, postvention, and also focuses a big part on not just how do we play this whack-a-mole mentality with youth, but how do we support them once we've identified that risk. And so all the links I think will be dropped in the chat, or we'll get to you the slides, but these are the four top ones I'd suggest you start with. So moving on from there, if we look at the what is postvention, as I mentioned, it's circular, right? It's, looking back to my experience, experience of suicide, death, and it's hard for me to acknowledge this, but it did make me more at risk for suicide. So therefore, we're back into the prevention and therefore the intervention. So the most important part of postvention is that timing is critical. It's never too late to engage in postvention, but I know a lot of times schools or districts will reach out to me or other supports days or weeks or even months afterwards. And I can't say how important it is that when we know that a suicide has occurred, that we have a plan in place and that we're ready to go into it right away the next day. So that means that the second most important part, or equal importance, is that we have a plan in place ahead of time. And it's hard to acknowledge, that we need to have a plan. We want to assume that this will never happen, but the potential damage that can occur if we're not prepared to our youth, which is our utmost responsibility, is to keep them safe, is if we don't have a plan in place ahead of time. So on the next few slides, I'll talk to you a little bit more about some of the resources to get a plan, but we have a responsibility, we have an accountability to not wait for a tragedy and to realize that, yeah, it's likely that many of us will experience a suicide death in our schools or our communities while we work in this field. And to make a comparison, and I'm not trying to say we shouldn't have fire drills in schools, but if we were to do a survey of how many of you have been part of a fire drill, or how many fire drills have you been a part of, versus how many of you have actually been involved in a school that's on fire, and then we compare that to, well, how many of you have been part of a postvention plan, and then how many of you have actually been part of a school community that has been impacted by suicide, I'm willing to bet the ratio would be a little bit different than we might expect. So again, we should still do fire drills, but it's just something we should be thinking about. So on the next slide, why do we do postvention? The reality is that a lot of times, like I said when I started, we're unsure what do we do? And when we have complacency or we're fearful about our actions, that we don't want to do any harm, what we inadvertently oftentimes do is cause harm. A lot of people are so worried about what to say or what to do that in that space where we're worrying about what to do and what to say, the worst thing that we can do is nothing. And in fact, the most important thing when people say, well, what do I say to somebody who's thinking about suicide or considering suicide? The most important thing we can do is simply to hold space and to listen. So that's the first part, is oftentimes schools are unsure because we haven't taken the time to look at it. And the reality is that there's certain practices that many schools still engage in that actually increase risk. One of the key spaces, I think, is around memorialization. A lot of schools are unsure how to deal with memorials. Well, the youth who died in a car accident or from an illness got a tree or a plaque. Should we do that for the student who died by suicide, or how do we change that process? Um, I think also just in general responding to, um, you know, communication. Well, the parents said that we can't confirm the cause of death. Well, does that mean that you shouldn't be communicating about suicide? And that's not necessarily true. Legally, you can't confirm that that student died by suicide, but that doesn't mean that in the response to a suicide with social media and all the conversations that we shouldn't be also giving resources and supports out to our youth. And what we do absolutely know is that suicide contagion is much more prevalent among youth, whether it's a public figure, somebody in the school community, somebody that they know. Um, we we absolutely know that postvention is one of the most important parts of prevention, and not just for the youth who were directly impacted, not just for their best friends, not just for their teammates or their classmates, but in postvention, we need to be looking at any youth who has previously been identified to be at risk for suicide. We need to look at youth who have experienced a loss, whatever the cause of death in their family or their inner circle. Any youth that might be activated because of this response. We really need to throw a wide net out. And I think a lot of leadership oftentimes wants to get back to normal after a suicide death. And when I come into a school setting and and I don't mean this dismissively, but just in support, hold the hand of a leadership team. Most important thing I can try to remind them is there is no normal right now. Like, normal is so far away, we're not going to get back there. But also to be prepared for, this is not a 1 day or a 1 week or a 1 month response. This is something that your school community is going to be impacted by, not just your students, your staff, your parents, your guardians, anybody who's in touch with that community. So on the next slide, I want to give you a little piece of homework. This is called the postvention checklist. This is actually from the SAMHSA toolkit. I think the SDCOE team has actually modified this a little bit to bring it up to modern times. But if you do nothing else regarding postvention, you don't read the resources, you don't create a policy, if you download this item, it's 2 pages front and back. It takes you steps 1 through 20. If you have nothing else in place, at least identify, who is our primary, who is our secondary. It starts from verifying the death. As strange as this sounds, I've had schools who have gone into a full postvention phase without ever verifying the death, and next day the student walks in and sits down, and it was just this online bullying thing. But it also goes to who's going to contact the parents, to who's going to remove them from the roll call. One of the most traumatic things I hear from parents is the day after their child dies by suicide, they get a robocall from the school that says, "Hey, your student is absent." And it breaks my heart to think about what that experience is like. So again, this is your homework. If you do nothing else, please download this. SDCOE, Heather, not to put you on the spot, if you have your updated version, if you can drop it or we can send it out, at least please start here and use that as momentum to encourage your leadership, your school board, your administration, your PTA, that we can't just think. Because one of the most frustrating things in my work is that we'll do a prevention webinar presentation for parents in a school of 3,000 kids, and we have 5 parents show up. We do a presentation on suicide prevention after a suicide death has occurred, and the gym is packed, and it breaks my heart. We need to do a much better job of not just engaging our parents or guardians, but everybody in a prevention. Acknowledging, and we didn't talk about the data, but if we know that 1 in 10 youth will think about them, or 1 in 5 youth will think about, and 1 in 10 youth will attempt, we have to hold ourselves to a higher accountability, and also hold parents, guardians, leadership, PTAs, school boards, to say this isn't something we can just do in a panic mode. So I'm not sure. I think that might be my last slide. I might have more slides. I think that's it. Okay. So we didn't add some slides. Since I still have a couple minutes, and CDE, please feel free to cut me off. I did have 2 other notes I wanted to mention before we go today. One of them is around screening and assessment. I do a training on suicide risk screening, and I think one of the big issues when we talk about screening, assessment, and the intervention phase of youth suicide is that we mistakenly believe that those 2 words are interchangeable. And they are absolutely not. A screening can be conducted by anyone from a janitor to a security guard to a food service worker, an educator, a counselor, an administrator, or a mental health professional. But that a full suicide risk assessment should only be conducted by a properly trained mental health professional. And so I mention that because a lot of our language interchanges those terms and they're simply not interchangeable. And so that is really something that you want to be looking at in your policies and your procedures. And I think it also applies back again, all three phases: prevention, intervention, postvention. And the last thing I want to mention, and this is really based on some work from a colleague of mine, Dr. Joyce Chu, we also have to be doing a much better job of bringing culture into suicide prevention. For years and years, we've kind of worked off this cookie cutter list of what suicide looks like in youth. And Dr. Joyce Chu and her team at Palo Alto University, they have a really powerful paper, and I'll drop it in the chat in a second, called The Cultural Theory and Model of Suicide Prevention. And what they explore in that is that idioms of distress, or what we refer to as warning signs, can vary. You know, I think a lot of communities I've worked with, they're shocked that the perfectionist or the high achieving student died by suicide. I remember a few years ago, a detective came to me after a young individual died by suicide. She was 13 years old, and they said, "I don't get it. She was ASB president, 4.0 student in the orchestra. Why is this young lady who is everything to everyone consider suicide?" And I just responded. I said, "Detective, you just answered your own question. A 13-year-old student shouldn't have to feel the pressure to be everything to everyone." So I mentioned that, and that's just one example, but we really have to broaden our horizons about what do warning signs and what do risk factors look like among youth. And if I were to say one thing to, educators who are like, what's the one thing that I should be looking for? What are the warning signs? The most important thing that I could tell anyone, parent, guardian, staff member, friend, loved one, partner, is trust your instincts. If something doesn't feel right, it's probably not right. And the most important thing that we can do to prevent suicide is be willing to talk about it. Just because a youth says they're thinking about suicide does not mean they're going to spontaneously combust. If someone says they're thinking about suicide, my response is always, "I'm sorry to hear that you're in so much pain. What can I do to help?" And maybe they don't even know. And sometimes just sitting in the mud with somebody and holding their hand and telling them that you love them and that you're not going to go anywhere, and even if you don't have all the answers, that can be enough for them to hold on for a little bit. So with that, I hope you'll check out Creating Change, Youth Creating Change, Directing Change, but I think I'm out of time, so I'll turn it over to the next speaker.
Hi, Stan. Thank you again. And to all of our attendees, we will be dropping the links for you in the chat, as well as sharing the slides and the recording. I would like to next introduce Carrie Rangel. She is boots on the ground, and she's going to share with us what this looks like at an LEA. Christy is the lead clinician for Selma Unified and is a licensed therapist, trauma specialist, certified in animal-assisted psychotherapy. Christy works with the Selma Unified School District clinicians, co-therapists, who I'm very excited for you to meet, Jetter, Scout, and soon to be Judge, to provide support to our students, staff, and Selma community, and build connections to decrease the stigma associated with mental health. Christy, we're looking forward to your presentation.
Well, thank you for having me. So within Selma Unified School District, we can go ahead and go on to the next slide. Selma Unified is, we're a rural community. We are on the outskirts of Fresno. Selma Unified, we have about 6,100 students. We have 6 elementary schools and 1 high school, 1 alternative, and 1 middle school, along with 1 community day school. Our mental health clinicians, we have a team of 6 clinicians, including myself, is 7 as a lead mental health clinician. We have 7 school social workers with their PPS, and we have 2 certified professional therapy dogs, and as mentioned, 1 in training, which is Judge. I'm just going to provide a brief overview of what it looks like when we're responding to a student who's at risk for suicide. So if you can go on to the next slide, please. So when a student is first identified as having thoughts, making statements, drawings, posting things on social media, and if they are at school, the site is the school staff and the site have been notified to contact the admin immediately, and not to leave the student alone. From there, the school social worker or the school psych, if the student has an IEP, if they're SPED, then the school psych will take the lead with initiating the Columbia Suicide Severity Rating Scale screener, along with collecting information and printing demographics and so on. If the student answers yes to the first few questions on the screener, they will then contact the site-assigned mental health clinician. If they're not available, then they will contact myself. From there, we'll to determine the level of risk. It's a lot of collaborating and a lot of consulting that we provide as we are taking on, these serious situations, because oftentimes the students may feel like they're alone in this, and we don't want them to ever feel like they're alone. And so we do our best to provide that ongoing support. So through this process, somebody, again, is always with the student. And I like having two clinicians or two people on board as we're conducting this, because I feel like the student has that connection and they're able to feel safe. And at times in the beginning, they may say, like, I am having thoughts of wanting to die or kill myself. And, as we continue to provide that support and we're there with the student, our hope is to give them hope. And so when we contact our school resource officer, and we notify our site admin of what's going on and where we're at with things, we work as a team, because we want the student to know that we're all there to care for them. We develop a plan of action based on the student's responses. We will contact parents for safety planning. We always want parents involved or guardians. Even if it's low risk, we still want parents to come in so we can go over the student's safety plan and identify different ways that the parents can support the student at home and at school. If we feel that the student is at high risk, at that point, our SRO steps in and takes over, and he will then contact Kingsview, which is our crisis response team. We will collaborate with Kingsview and the parents and make sure everybody is on the same page on how we're going to, the next steps. We really want to make sure that we are in line with making sure parents are notified each step of the way, because oftentimes parents, they may feel defeated when they're going through the situation and feel like they're alone. So we want to make sure parents feel supported through this. If a student is sent to Exodus, which is our crisis stabilization center, we work with the parents. We have the parents sign a notification form, releases of information, and if the student is over the age of 12, we do have the student sign that ROI as well. So we can be in contact with Exodus and with the parents through this entire process. So the mental health clinician will take the lead, and they will continue to provide that ongoing support with the parent and with the student, just making sure that, this parent knows, like, I'm having difficulty, making contact with the Crisis Stabilization Center. Can you help me? So we want to make sure that we're there to really support the parents as well through this process. We will often, after the student is sent to Kingsview or to Exodus, we schedule a reentry meeting with the parents. So we always ask parents, contact us, let us know when the student's going to be released. If we don't hear from a parent, at least, once a day, we're contacting the parent and asking, where are we at? Do we know when the student's going to be released? So we can make sure that we have that reentry meeting prior to the student coming back onto campus and going on with their regular schedule. For the reentry meeting, we want to have, if the student has an IEP, we want to make sure that the case manager is involved in that, the school psychologist. We also want to make sure that the social worker is there as well, the nurse, an administrator, and a school counselor, because we want to make sure that the student feels wrapped with support when they return, so we can be there to help them and create that wellness plan upon their return as well. Some of the important points I want to bring up again is parents are brought in and participate in the safety planning process. So if a student is high risk and if a student is low risk, again, we want parents, guardians to be a part of this process. An important thing to also note is that if a student has an IEP or if they're a SPED student, We want to know what is their level of cognitive functioning. We want to know if there's any learning deficits or comprehension deficits. So we know, how to approach and ask the questions with the student. So we really do collaborate and work together as a team with our site admin, school social workers, school psychologists, because we want to make sure that we do everything we can to support the student. And there we have, that's one of our therapy dogs, You're Not Alone. So Jeter has been a big part of helping us support students as well. And so we do provide different cards and so on for the kids to take, and they have this as part of their safety plan with the crisis numbers as well. If you want to move on to the next slide. For suicide prevention and to reduce the stigma, all staff are involved in training prior to school starting during the professional development time. This year, we rolled out Signs of Suicide for our secondary, for our high school, and then for our TK through 8th, the staff went through Keenan training that provided the suicide awareness and prevention as well. We also provide parent training on suicide prevention, and it's offered district-wide to all parents. But we also want the parents to know what the curriculum is, the SOS, Signs of Suicide, so they have an idea of the terminology we're going to be using with the students. So we provide that training prior to providing it to the students at the secondary level. For TK through 8th, we utilize and implement the Start With Hello campaign and the Say Something campaign as well. It's through the Sandy Hook Promise. It's really great curriculum for students at the elementary level and for middle school. Again, for our high school, we implemented Signs of Suicide. To date, all of our high school students have been trained in Signs of Suicide. So it's a curriculum where we, I think it was this past week, we trained, I want to say around 400 of our freshmen were all trained in this. And so we're really proud of that. And so there's a video that we show the students with some follow-up questions and discussions, and it's really interactive, and the students were really involved this year. It was really great to have that feedback from them. This year we also had Saluna. They joined our training. So it was really great because at the end of our Signs of Suicide training, a Saluna rep came in and went over the Saluna app with the students, discussed the different resources that go with it and how they can seek out those different supports. And it was really great, and our students really seemed to enjoy it as well. We provide a lot of activities throughout the year, and parent engagement trainings are also offered. And just making sure our mental health clinicians and school social workers and school psychs were visible on campuses. Like the students know where to find us. At the high school, prior to school starting, during the freshman orientation, they will take the students around and show them around campus. And so they know where to locate our offices and where to find us if they need help. At our high school, we have it set up where our library is kind of like our hub of support services. We have, my office is in there, and I'm there 4 days a week. We also have another mental health clinician. He is there 5 days a week, and we have a school social worker who's at our high school 5 days a week. So students know that if they go to the library, they're going to get help. We have a QR code set up, so students know that if they scan the QR code, we will be following up with them. And so we've had an increase of students referring themselves and referring their friends. So it's been really great to have that. And then our big thing too is we have our therapy dogs, Jeter and Scout. Scout is there in that picture with our school resource officer. That was one of our activities where students were making bracelets with different positive statements and just with the suicide awareness and prevention colors, and just to raise that awareness. And we had a lot of our students involved. And we have Jeter and Scout plushies, which I'll share a little bit more on the next slide, please. So Jeter and Scout and Judge, they've really impacted our district and our community with decreasing the stigma related to mental health, and they've really helped us build connections with students. Jeter he was board approved in 2016, so he's been a big part of my work here with our students and the Selma community. He has really helped me when I've been conducting the Columbia screeners with students. Jeter will be in session with me, and he has it's really amazing. It's really hard to explain. You have to see it, but we've had students who have been completely shut down, flat affect, not responding, head down, and Jeter will, I'll ask for permission if Jeter can go to the student, and the student will either nod or they'll give me a thumbs up if they're okay with it. But sometimes the students will even just put their hand down and Jeter will go and he like nudges their hand. And we had a moment where Jeter, he kept nudging the student's hand. So the student started petting Jeter, and then Jeter jumped up on the student's lap. And it was just amazing to see the student, like he was not responding to me, but he was responding to Jeter. We just started to see the tears coming down his face. And, he was just crying there with Jeter. And so Jeter was just there and he was embracing him. And it was just so great to see how the student just felt that comfort and that acceptance with Jeter, where he then was responding to my questions. So Jeter was there to support him throughout the entire time we were there, and it was just so great. And that student, if after that, if you were to ask him who his therapist was, he would say Jeter. I don't think the students even know my name; they just usually call me Jeter or Scout's mom. But Jeter and Scout have been such a huge impact. You can see Scout; she's there applying pressure to one of our students who was having a difficult time. So Scout, with the student's permission, goes up and then she starts to apply pressure onto the student's leg. So it's like having that, like a weighted blanket. And so then the student will start to breathe with Scout to help them regulate as well. So it's just like a release of oxytocin. And it's just so amazing to see that impact that the students have with Jeter and Scout and soon to be Judge. But building that connection, that sense of safety with our kids. Down below, you could see Jeter, the connection he has with that student. It's just the eye contact, that oxytocin being released and them forming those connections. And that's what we really try to do. And so at the elementary sites, I try to push in to provide SEL lessons and go to lunchtime activities and so on. So the students know who Jeter and Scout are. And so when they get to the high school, they know that if they go to the high school, they know if they see Jeter and Scout, they know that that's going to be help. And so when we first started, students, some parents did not want Jeter and Scout or Jeter to be associated with any of their students. There was that stigma associated with mental health, and even the term of, just therapy dogs. So as Jeter became more well-known within our community and within our school district, no one even questions it anymore. So if they're an athlete, if they're in band, if they're in choir, we support everyone. So no one even asks if they come into our office or they're with Jeter or Scout, because it's just they have that connection with them, and they really do help reduce that stigma. The Jeter the therapy dog and Scout the therapy dog, the Today I Feel, we actually have these posted at our high school, and the students, even at the high school level, they don't have the words to express what they're feeling. And so they use this to point where they're at. Scout has really helped as well with when I'm conducting the Columbia screener, with helping students just feel grounded and feel safe. So they feel like they can then open up and share what they're going through. And we're able to build that connection. And then they know that they can just come in during lunchtime and come and see Jeter or Scout. So we do offer, we do have their little plushies. So this is Scout here, and then this is Jeter. And so the students, this is a hot commodity within our school district and our community, because the students, they get to take these home. And it's a reminder for them that they're not alone, and that Jeter and Scout, myself, our entire mental health team and our community and district, we care about them. And so our students, even at the high school level, like this week, to get students to respond and answer questions, like if we said we were going to offer a Jeter Scout plushie, everyone's hand was raised because this is what they wanted. So they get to have this, it's like a little toolkit for them to have their own little plushie, and it's really soft. And at the high school level too, our teachers will let students know, are you having a tough time? And students will say, yeah, I need to go see Jeter. So the teachers already know, and they send them to the library. It's not necessarily they need to see Jeter or they need to see Scout, but they know that they're going to get that help that they need and want in that moment. And so it's just really amazing to see the impact that the therapy dogs can have on a community and a school district with decreasing the stigma and just helping build those connections. Jeter and Scout, we try to attend as many events as we can within the community. Scout, she plays different games. She knows how to play Hungry Hungry Hippo. She knows how to bark to 5 because she is 5 years old. She knows her different colors and she identifies those and plays the piano and the drums. And so the students come in, they'll get, their little moment and dose of regulation, and they're able to then relate and connect. And, their prefrontal cortex is then ready to go and they're ready to go back to class. So sometimes they just need those little doses, and that's what Jeter and Scout do provide. As far as Jeter has his little Mercedes there, and he's going to be retiring out this school year. As he'll be 14 in November. So Scout will be taking over full time, and then Judge will be coming on board in February and March to help Scout support our students and continue to build those connections. And I think that is it, unless I have another slide.
Thank you so much, Christy, for your wonderful and much needed resources. Now, please take a mindful moment with me to send out loving kindness. Let's start by taking a deep breath. Close your eyes if you want to. And to ourselves, we say, may I be well. May I be happy. May I be safe. May I live with ease. For our loved ones, we say, may you be well. May you be happy. May you be safe. And may you live with ease. And to our communities and the world, may you be well. May you be happy. May you be safe. May you live with ease. And now we're going to transition to our panelists. We are very excited and honored to have an amazing panel of experts who will address many of your questions entered at registration. Ahmad Barami is the Division Manager of Community Planning and Quality Management for Fresno County Department. He is also the Equity Services Manager for the department and has worked around suicide prevention for the last 10 years. Marlon Morgan is the founder and CEO of the California-based national nonprofit organization, Wellness Together School Mental Health. He worked with school districts, universities, state offices of education, and the U.S. Department of Education to increase awareness, advocacy, and access to mental health intervention for students, families, and school staff. Dr. Kendra Reed is a clinical psychologist and vice president of therapy at Brightline. Previously, she served as the director of the Mood and Anxiety programs at the Seattle Children's Hospital. She specializes in the treatment of youth with anxiety disorders and OCD from a cognitive behavioral therapy perspective. And Dr. Sohail Sood is the director of Children and Youth Behavioral Health Initiative. Sarah Mann is the section chief for the Office of Suicide Prevention at the California Department of Public Health. And you've already met Christy Rangel, Heather Nemore, Stan Collins, and Dr. Tooley. Dr. Sequeira is our moderator. The room is yours.
Thank you, Pam. If the panelists could please put their camera on, that would be wonderful. So this part of the program, I am elated that we have the opportunity to have statewide experts in the room to answer many of the questions that were proposed to us when you registered. In addition, we will add a couple of the questions that came in the chat that we feel or in the questions and answers feature that we feel is important for everyone to hear the same message. So I'm going to go to the questions. And okay, Christy, I'm going to start with you. Do you have any resources for reentry plans with students who have made attempts? And could you walk us through what a reentry plan looks like?
Yes, and I'm probably going to ask Stan to jump in here because we were very fortunate to have Stan come in with Fresno County and provide different trainings and resources for us through our student work group or our student workbook group. But the books that Stan had shared were all the resources that we used for the reentry. Let me see, the suicide in schools policy to practice, the suicide intervention toolkit. Those are all different resources that we have implemented and utilized and have just used the templates to work within our district. Stan, if you want to.
Yeah, I'd be happy to. I would really encourage you to look at the policy to practice toolkit from SDCOE. They have what I think are the best reentry forms because what I like about them, oftentimes you think about reentry in terms of 504 and IEPs and very formal accommodations. And there's a section in there that talks about the little things, like for example, let's say a student is now on medication. Do we really have to get them up at 10:35 in the middle of third period to go take their medication? Or can we work with their psychiatrist and their physician to say, if we push it up 15 minutes, they could sneak by during class break and they don't have that stigmatization of having to leave. So there's a lot of like those minor things, or does that science teacher really need that last quiz to be completed, or can they just give them a pass? It's those small things that sometimes we focus on when we're under stress. So I would start there. And I think the last thing I'd say, and sorry to keep talking, but it's never too late to do reentry. We might not find out that a student experienced these issues for days or weeks. And it's not just if they're hospitalized or if they're an attempt. Any time that a youth has been identified at suicide risk or mental health distress, they're re-entering school into a new world. And so we have to always step in and create that space.
And I'll just add on top of that too. Usually after 2 weeks, we will revisit and have another, ask the student if they feel like they need an updated plan in place or if there's anything else that we need to do to continue to accommodate and support them.
And if I could just add something we're working on in San Diego, ideally, really, these reentry plans are best when we can communicate and share information with the hospitals and the crisis centers and so forth. We're working on a pilot in San Diego where we're working with the American Academy of Pediatrics, and they're very interested in the same reentry work we're doing to be able to, we've created a new reentry plan with the medical info they're willing to share and then the school info. So as we launch that, always happy to share that other reentry plan when you do have medical partners at the table willing to share.
Thank you for that. And if you could drop in the chat, please, the link to that, because I know, as a former high school principal, looking at reentry plans and modifying to meet the needs of our school community is really important. And then, Christy, I just want to give you accolades. We have to remember we assess and we reassess. And I love that you check back in a couple weeks to see where they are. And maybe the plan's working for them. Maybe it's not working. So thank you very much for that contribution to the conversation. Okay. The next question we have is for Ahmad. This question is for you. And we've said it before, Ahmad, but we got to remember we learn through multiple ways of learning information from multiple people. So if you wouldn't mind, please, what are the warning signs to look for and how to help someone who doesn't want to be helped?
That's a tough one because I think if that's a question we could answer, especially when we're talking about for adults, we would probably have maybe not as many people out of care, maybe not as many people ending up in crisis, a lot of state initiatives, CARE Act, a lot of those efforts are to try to engage those individuals who've not done. There's probably folks with clinical background. I'm thinking of like Marlon that might be able to speak to the specific legalese in there. Stan said, a lot of it I think has to do with, the engagement. How are you engaging the person? I mean, does it feel like something's going to be done to them versus like you're helping them? It's I think, and somebody else shared it earlier. I think it was Heather, just and maybe Chrissy, the number of students that you train and to where you can normalize the discussion and you reduce the stigma around it, I think is huge because they're probably going to be the ones that are going to be more likely to see the signs. They're more likely to see the red flags. I'll share a real quick story of an example of that. We had a student, a middle schooler and a high schooler. high schooler texted their friend who was in the middle schooler and basically was saying that they had the means, they had some pills, they were in the restroom, and they were going to take their own life. The student who they texted to is obviously really concerned, scared, freaked out, didn't know what to do, was afraid to go tell the teacher because they were worried, like, would they get in trouble? Would their friend get in trouble? What do they do? Well, on their water bottle, they had a little 988 sticker, and they go, ooh. And so they asked, like, hey, can I go to the restroom? They went to the restroom. They contacted 988, said, this is my friend. This is where they're at. This is what's going on. 988 dispatched a person of first responders to the school. School has no idea what's going on because it's a different school. All of a sudden, you got EMS, law enforcement, everyone showing up to the school going, to respond to it. Needless to say, they were able to get to the student and save that student's life. Now, it would have been great if the teacher can see the sign. Like, that was really an odd way that Carrie left the restroom. But it's hard. If we're able to normalize and really build a culture and train up our students, then they will reach out to each other. And if someone now knows the tools, like that student's like, what do I do? Do I tell the teacher? What do I say? If nothing else, they go, I can text 988 and I can tell them about my friend, and they can, mobilize and do help. So I don't know if that really answers the question you had, but I think, there's a lot of variables that go to what do you do with someone that doesn't want help. And to Stan's, earlier point that he made, which I think is really kind of those epiphanies. It's not like someone that's contemplating suicide wants to die. It's they don't want to live in this because they don't feel there's any hope. And a lot of times when we talk about things like ACEs and a lot of those other things, having that caring individual, having that one adult that'll actually say, like, man, I'm sorry you're going through that. What can I do? How can I help? May be enough. And we've seen from, utilizing the service dogs, that sometimes they just need a pathway. Now people may opt not to do those services, and there could be a lot of reasons why there's a stigma in it. Maybe they're not really understanding how it's impacting. And a lot of times we present mental health as, again, something you have to overcome. You have to do these services to get back to school. You've got to do these services so you can go back to class. You can, versus really, presenting as a way, this is something that we're going to do that's going to help your life be better. This is something we're going to do that's going to help you be happier. And so a lot of it, I think, has to do with how we frame the presentation and the information.
That's really good information, Ahmad. And when you shared that story with me in a meeting about the young student who saw it on a water bottle, I have now decorated my cell phone, my car, everything I can. And I'm not being funny about it. I genuinely mean that. So if someone sees it, then it might be a resource. And later on, California Department of Public Health will be showing us a video on what does it look like when you call 988? Because there's a fear about calling 988. Now, what does it look like and what does it feel like? Dr. Tully, I see your hand up.
Yeah, thank you. I just wanted to plus one a couple of things that Ahmad said. I think the first thing that's so striking about that story for the students helping each other is the importance of community, and that community being really safe, because it just comes back down to this ground truth that talking and listening is the most important intervention we can give. And the we isn't just us as the trusted adults, right? The we is the community surrounding that young person. And so ways of fostering that community in your classrooms, in your schools, in those spaces that you're in, while it may not feel like it's directly related to suicide prevention, it is. So any kinds of community fostering exercises that you're doing to help young people talk to each other, talk to adults in their lives, is going to create that safety that they can come to you or other people when they have something big to talk about. And I think the last thing I'll say is that we do know from research that people in general, and young people particularly, are more likely to reveal and talk about their suicidal ideation and associated distressing feelings around self-harm when they're in an anonymous setting, which is why text and crisis helplines are so helpful. And I just want to sort of plug that the Soluna platform that we've built with Dr. Sood and the CYBHI program is an anonymous setting with a peer community support space. So if young people are already on it and they already feel like they have a community around them that they can talk to and chat to and get support from, they might go there first when that moment is happening for them in the bathroom. If they're not quite ready to text their friend, if they're not quite ready to call 988, they might be ready to talk, to like post about it on a forum or talk to a coach in an anonymous setting. And then that coach is trained to work with them, to do a risk assessment, to figure out, all right, what actually is the right step here for this young person, and follow the protocol from there. So build that community and give them these other options for community in the absence of with anonymity.
I think that's so important, just to jump in here, just thinking about the ecosystem of the child or the adolescent in question here, and that's how we can support in so many different avenues. I think the other piece that I wanted to talk about is that as part of that community, really being thoughtful about how we talk about mental health and how we might, in addition to just like destigmatizing, really mystify, if that's a word, like what happens when you say like, hey, I really need help. What does help look like? What does help mean in a way? Because the children and teenagers that I've worked with are terrified that there is only one thing that happens when you say that you're experiencing suicidal ideation, and it means that you are immediately admitted to a hospital. And while that might be true for some extreme circumstances, depending on the levels of risk, as Dr. Tully outlined for us here at the beginning, for the vast majority of situations, that really isn't the indicated intervention for youth here. And so we really want to be thoughtful about how we can demystify what happens when you ask for help. In addition to like making sure you're not getting in trouble and all of that, but we're going to talk with you. We're going to figure out a plan together. Here's what that means. And I think that can really help support people in feeling like help is approachable. Help is something that I can receive and I have supports available.
Yeah, if I can just jump in, Dr. Reed, thank you for saying that, because I think, especially working in this field for so long, like youth are so used to seeing us press the red button. A kid says suicide, we press the red button. Now they're in handcuffs in the back of a police car and they're headed to the hospital. Why would I ever talk about suicide if that's what I think is going to happen to me? So I know that our processes have changed and that doesn't happen. And like you said, it should very rarely happen. There's very few circumstances that indicate that. But we really have to do a better job of not just communicating to our staff and our communities, but to our students and say, no, if you are thinking about suicide, we're just going to sit down with you and talk about suicide. And that's okay. It's not like it's a big deal, but at the same time, it's not a big deal.
Thank you. I'm sorry to rush us through, but I want to make sure we get to as many questions as we can. I just want to echo and really cement something that Dr. Tully was saying about, and we've had this discussion about the Soluna app, right? So it's a free in moments, Dr. Tully, if I'm saying wrong, moment therapy, a resource for our students. But what we were talking about is how do we get the information to the students? I can send an email to all the superintendents, the counties, easy, but how do we get it like in the classroom? How do we get it? And she had a wonderful idea of on bathroom stalls. When you close the bathroom stall, there's a QR code, and there is a higher chance that perhaps with that confidential space, the student may scan it and get the support they need. I loved that idea. We are also dropping a bunch of toolkits and information, the Soluna app, Bright Life, which is geared towards elementary. We're going to talk about that a little bit more, but I just want to thank you for that. So next up, I have Dr. Sood. I'm going to ask a question of, and Dr. Sood and I meet often, and the same theme I say to him all the time is, Dr. Sood, I didn't know about these resources. I didn't know these were available. How do we get the information to the school sites? We talk about it all the time. And I'm really excited to have him here. I always am excited to be with him. And the question I have for you, Dr. Sood, is what resources are available to a school during a post-vention of a completed suicide? How can schools get clinicians on site?
Thanks, Carrie, and good to be with you and good to be with everybody today. As background, Carrie and I get to chat frequently, in part because what we're doing at the California Health and Human Services Agency is trying to invest very significantly in a prevention-oriented manner, a youth-centered manner, as has been discussed many times here, and an equity-focused manner to reimagine the way we support one another. And to reimagine the way we take care of our kids. So the initiative overall is called the Children and Youth Behavioral Health Initiative, and we can put more links in the chat around that. But to your particular question about what resources are available for a school in that post-vention space, first, I would acknowledge the great insights and resources that have already been shared by Stan and by many others on this call. And then second, I actually want to pass, if it's okay, to Sarah Mann from the Department of Public Health, who is doing work on exactly this topic. And part of that, as a little bit of a preview to it, is that schools should not feel alone. in this space, right? We're talking a lot about students not feeling alone and that students have resources and connections that need to be made and they should be made. So too do schools, so too do school districts, LEAs, and even county offices of education. There are many partners in the behavioral health space, in the public health space, your community doctors. We all want to lean in and support our students and our schools and our children. And some of the work that the Department of Public Health is exactly on that matter. So I'll pass to you, Sarah.
Sure. I can just quickly mention, as part of CYBHI, we do have a funded project called our Youth Suicide Reporting and Crisis Response Pilot Program. So we are funding 10 counties throughout our state to pilot this and really go out and kind of learn more about their county and what their current structures and supports look like around reporting attempts and deaths by suicide, as well as the crisis response services that they are providing. So looking at the existing supports and identifying the gaps that are there, and really trying to work to identify ways to start building partnerships and bridging some of those gaps to provide more comprehensive reporting and crisis response. So we are in the last year of that pilot. So hopefully after this, we will have a lot of different examples of best practices and things that were effective within those 10 counties that we'll be able to share in spaces like this. So more to come, I think, as we learn more from that project.
Yeah, and if I can just add a little bit onto that as well. Thanks, Sarah. Stan mentioned oftentimes when we see a kid in crisis, we push that red alarm button, and then things fall into place for that child that may not be in the best interest always of that child. We should instead be pushing that red alarm button to get all of our community partners on alert, right? Of how can we collectively come in and support. And so just in addition to the work that's happening in those 10 pilot counties, I would say pick up the phone when you are concerned and speak to either those up the ranks of the education world, right? To your school district, if you're a school, to your county office of education, or over to great folks like Ahmad at your county behavioral health department, and others that are there to really lend support in those times of crisis.
And
Thank you. Go ahead. Sorry, Stan.
Sorry, really quick. I think that's also part of having a post-vention in place ahead of time.
Mm-hmm.
Talk to your partners. Many of you might not be aware that over the last couple of years, the majority of California counties have created a suicide prevention plan, which led to the creation of a suicide prevention council. Many of those councils have school-specific or post-vention specific subcommittees. So again, reaching out ahead of time so you know who do I have? Who can I call on Sunday night at 9 o'clock and say, hey, dude, we're having a meeting. How can I help?
That's really good. But I do want to acknowledge, because I think that, we have the lens of the CDE and of supporting our counties and our districts. They are reaching out to us, and some of them, they don't have a plan in place, and they're asking, like, what do you do? How do we get resources? But I love that what you're saying, Dr. Suhail, about get those wraparound supports, and Stan saying, find out in advance, so you can make those calls. I think that's really important. I was just going to call on you, Marlon. I have Marlon join the chat, and Marlon is the founder of Wellness Together, and he is also, there's an upcoming conference in October, and if you wouldn't mind, Marlon, dropping the link when you're done talking, that would be awesome too. What were you going to share?
Great. Yeah, I think, Carrie, and thanks to everyone who's here. This is an incredible webinar, probably some of the most practical advice I've heard provided to educators. And so as a former school counselor and as a therapist, I wanted to mention again that, and Carrie, you asked, how do we get therapists on campus, which is also an important part, especially of those tier 3 interventions, whenever we can, to assist and work with school counselors, school psychologists. And so I would say to go into your community, as Dr. Sood mentioned, find out who the trusted providers are. There's probably a nonprofit CBO in your community that also cares a lot about the students in your community, and you probably have a lot of the same students. You might know who that is if you've been working in the community for a while, and see if they'll do something innovative and work with you. Sometimes even HMOs will actually provide some resources or respond with therapists or access to therapists, so that frankly, it can help them in a way too, because a lot of the prevention that we can do in schools and the access we have to help students can actually make sure we keep students out of the emergency room, which can be even more traumatic, a lot of times. So I would just say, find out who your trusted partners are. That's the whole reason that we even existed, was to bridge those connections, to put therapists on campus and make sure that they're trained and can speak, and sometimes code switch even between the medical model and the education model, because that's really important as well.
Thank you very much. So I want to kind of circle back with you, Marlon. So what resources are available? And Ahmad, you might be able to know this, or Stan, I'm sure everyone knows it, for the families in a community that have experienced death by suicide. What would you, or who would you recommend that they go to get supports? Maybe they don't currently have the supports they need.
I think that, and Stan's probably going to be the better expert to talk about statewide. I just know locally in Fresno, we have a loss team, local outreach to survivors of suicide, which is actually a postvention model. Part of that is not just having a team that deploys to the incident and responds to the family or those involved, but as part of that, they're set up to provide ongoing support groups. So that could be someone that has experienced a suicide a loss of a suicide 20 years ago, or it could be 20 days ago. It doesn't matter. They're able to have that ongoing support. There's information that they send out. They highlight certain anniversaries. And some of the things that they also do is provide, we utilize and leverage the funding for that contract, to where they'll do up to 6 sessions with a therapist, specifically with clinicians trained to assist someone through a loss and grief related to suicide, because a grief and loss often that one experiences through suicide is different. It's a different grief than, in a different kind of loss. So it provides them with that. And if they need additional counseling after that, they can either be provided, linked out, whatever not. But each county is different. It just depends what they're set up. But there's a lot of organizations and entities in different counties that provide that support. And at minimum, if you're not aware of one, grab the back of like any insurance card, especially if you have commercial insurance, and kind of be like, hey, I need to get a therapist that can support the family. Oftentimes we think it's just the individual, the immediate, the students, the family, the faculty. We have a lot of faculty on here. We all have EAPs. It's not hard for us to reach out to EAP and say, hey, I need to see if I can get some type of a group session for my staff. How can we do that? So there's a lot of options, but we leverage, as part of our loss team, the postvention is not just the direct, but it's also the counseling, the ongoing support groups, education groups. And that's also where we encourage people, depending on how they feel and where they're at, to potentially maybe become volunteers, because they've had that lived experience, and how they can help inform others and train others. So we've had a number of people who become trainers in QPR and other things, because they're utilizing and leveraging that lived experience, like Stan has done and other people have done. But I think there's folks here that can answer that question better statewide. I'm limited to this.
Well, thanks, Ahmad, for the shout out and always being so kind. But yeah, I think there's a handful of counties across the state that have loss teams like Fresno, which I think is the gold standard. But at a minimum, I think we neglect the idea of creating even a temporary support group. There's a lot of toolkits out there that for staff, for students. I also think we need to broaden our definition of what is a loss survivor, right? We also often think of loss survivors as the 10 kids who hung out with them on the weekends. If you've ever been in a community that lost a student, you are a loss survivor, more than likely, So I think we have to first accept that, not to label people, but accept that label. Like, I'm comfortable with that label. So loss teams, most counties now have survivors of suicide loss support groups. So reaching out to that, but also when reaching out to a therapist, I think it's important to be aware that it's not just and this is something Fresno does, Tulare does, not just a mental health professional, but a mental health professional who specializes in suicide bereavement. And we're really trying to increase that capacity across the state.
I would say too, just to add to that, Stan, I really like NAMI's family support groups, National Alliance of Mental Illness. A lot of counties do a very good job, and they're free. And if it's in your county, they know the community and can probably be likely to understand your situation even further than like a large, maybe nationwide resource. And then also the Trevor Project has some great family guides as well when it comes to postvention.
That's great. Would you mind
That
dropping
as well.
Lacey? Oh, sorry. Go ahead, Heather. Sorry.
A great resource for, our whole state is someone we use all the time is the National Center for School Crisis and Bereavement. It's through Children's Hospital Los Angeles, but Dr. Schoenfeld is our go-to, and he not only will provide trainings for staff, crisis support, he'll get on the phone with the superintendent and walk them through a postvention plan and so forth. So he's kind of our red button that we use, along with, of course, County Behavioral Health. We work together to deploy teams for postvention, along with Elizabeth Hospice, who provides grief bereavement support groups on sites and off. So other counties might not think of like hospice organizations, but many of them specialize in postvention and as it relates to schools and suicide. So
Thank you, Heather.
definitely tapping into all, but the National Center is really available to everyone.
I appreciate that. We'll drop those resources. Our time's limited. I really want to transition to California Department of Public Health. We're going to go over some data and resources. And one question I have to acknowledge that did not get answered was around elementary school, specifically because of the death by suicide in the younger students. And when talk about it and the resources will be discussed with California Department of Public Health. So thank you to the panelists. I love being in your space, and I appreciate you very much.
All right. Hi, everyone. My name is Sarah Mann. I'm with the Office of Suicide Prevention at the Department of Public Health. I know we only have a few minutes left, so we're going to try and hustle through this and be able to share as many really key points with you and takeaways for you all. If you can go to the next slide, please. I'm going to give a quick overview on our Office of Suicide Prevention. I'm going to pass it then to my colleague, Jonah Cox, who's a research scientist with the office. He's going to share more about the data that we have available specific to youth. And then I'm going to pass it to Darcy Pickens, who's going to share more about our Never a Bother Youth Suicide Prevention campaign. So really quickly, I just wanted to share a little high-level information about our Office of Suicide Prevention, just to make you all aware. We are relatively new. We were established in July of 2021 through AB 2112. And as you can see here, the mission of our Office of Suicide Prevention within the Department of Public Health is to address the root causes of suicide and self-harm injuries through things like strong partnerships, dissemination of data, and promotion of evidence-informed public health prevention strategies that create safe and healthy communities across California. An important part of AB 2112 that established the office also specifically called out the importance of our office focusing on groups disproportionately impacted by suicide. So that includes youth, Native American youth, older adults, veterans, and LGBTQ plus people. Next slide, please. Here's just a look at some of our current strategic priorities within the office. They fall into these 4 categories: communications, so thinking about things like reducing stigma and promoting suicide prevention strategies through public health communications. The second priority area is around creating safe and protective environments. This includes things like promoting lethal means safety, resiliency, and connectedness. The third category is postvention. So our office is doing, I had mentioned a bit about our reporting and crisis response pilot program. That's how we're trying to support local level postvention support systems to rapidly and comprehensively respond to suicide attempts and deaths. And then our last current priority area is around continuing education and training. So really trying to promote workforce and gatekeeper suicide training, both for our internal teams, since, like I said, we're a relatively new office, as well as partners across the state. And we do have a number of guiding principles that are kind of woven throughout our strategic priorities, including a real focus on infusing health equity throughout all of our work, both data evaluation and our program work. If you can go to the next slide, please. I think there's going to be some links in the chat for these, so I won't get into too much of the detail because I want to save time for others. But just a couple things to note: you can go to our website. There's a lot of great things there, including some recently created or updated social media shareables that can be used, promote through your social channels, as well as emails and newsletters. We have a number of webinars. We've partnered with Directing Change to get out a number of copies of the mental health thrival kits over the last few years. We have a very active listserv. You can sign up to receive up-to-date information from us. And then we also have our youth suicide prevention campaign, which we're going to talk about in just a minute. If you can go to the next slide. This is an example of some of the activities we're doing around continuing education and training. Through our office, we did sponsor 2 Zero Suicide Academies, where a number of organizations were able to attend for free. And we are continuing this year to support those organizations that were part of those trainings through some communities of practice as they help to implement the Zero Suicide Framework within their organizations. Next slide, please. And just some upcoming highlights for us. We did an initial needs assessment in kind of our second year of being established, and we're going to do another one this next, probably springtime. We really would encourage you all to join our listserv. That's how we'll get information out there when we release our needs assessment. We want to hear from you all. We want to hear from partners to know priorities around suicide prevention needs so that we can help to take that information and really create our own priorities for the office so that we can best serve the needs throughout California. There's information on the slide about an upcoming community of practice. We'll include a link in the chat around how to register. This month's community of practice is going to focus on suicide fatality review teams. And then lastly, just partnership development. We're similar to the needs assessment. We're always wanting to hear from partners and learn from people who have worked in this space for a very long time and find out how we as an office can help to provide support. So our email address is listed there. And I think that's my last slide. If we go to the next one. Okay, I'm going to pass it to Jonah now.
Thank you. I really appreciate being part of this conversation. You give me 5 minutes, I'll take 10. So I'm going to try to fast forward. Let's go ahead, maybe 5 slides ahead. We've touched on a lot of these topics that are very important, but I want to get to some of the broad overview that we have going on. So during COVID, there was a large transition for youth. We'll go ahead maybe 2 more slides. I think that'll be our first data slide. There was a big change for everybody, of course, as we all know. And so what was disappearing was this look at youth. When you looked at the state of California as a whole and you looked at the nation as a whole, there was a reduction in suicide. And it something that we observed when we broke it down by age demographics, we're seeing this rise. And so I want you to look here. This is 10 to 14-year-olds, 2018 and 2019, relatively steady rate. Low compared to adult populations at 1 per 100,000, but in 2020 is nearly doubled, and it stayed high in 2021. This self-harm rate we also observe was quite elevated, and what I'll note is that as youth transitioned to adults, this started to mirror more what we saw in the adult population with a slight dip in 2020. What I want to, as a broad overview, just state there were particular groups that were of concern. Youth who are female had a high raise in self-harm incidents and a higher increase in suicide rate. Youth who were Black, American Indian Alaskan Native youth, and youth who were Hispanic were groups that highlighted the concern to us. And we can go to the next slide. Again, I don't want to skip over things too much, but I know that if, again, I could talk heavily about this. We're seeing this trend for females here with the big increase in 2021. Next slide, please. And so again, this is mirroring 15 to 19-year-olds. We see that it looks pretty steady throughout this time period, but holding steady is actually quite concerning overall. I'm going to forfeit the rest of my time because I know that Darcy, I believe, has some important data about what we're doing about it. They're addressing the problem here and there. I guess what I want to highlight is that there is a problem and we are working on it. Darcy?
Dr. Cox, you're so nice, but please don't feel rushed. We can go over if we need to a little bit. But this is great information. If there's something you want to highlight, this is far too important. Literally, the mental health of our students is far too important. So please don't rush.
I appreciate that. Okay, well, let's go ahead to the next slide then. Here's where I want to point out this concern with the female versus male rate. So generally speaking, in the state of California and across the nation as well, it's about 3 to 3.5 times the rate of suicide for males compared to females. So there's a elevated rate of suicide for males compared to females. But if we're progressing through, we're seeing in 2020, this is a slight reduction in male suicide and a large increase for female youth suicide. So now it's less than double, which again, this disparity is alarming considering what the normal pattern would be. Next slide, please. Here we're getting into the 20 to 24-year-old. So these are young adults. And here we're seeing a pattern that is slightly mirroring what we're seeing in the adult population, where there's a dip in 2020 followed by a rebound in 2021. Next slide, please. Again, similar trend we are seeing here. You can see the pattern with the elevated suicide rate for males compared to females. Next slide, please. I think this slide is very important, and it's almost more important what's not here than what is here. This is suicide rates for 10 to 24-year-old youth in California by ethnicity, sex, and year. So we're able to see the developmental trend. Female youth, we're not seeing, and we're not seeing American Indian, Alaska Native youth. The reason why is because these are small counts, but small counts does not mean not important. When you have a small population size, a small count might have to be removed for identification purposes, but we could have very high rates still. What is important to clue in here, looking at this chart, the second cluster of bar chart here, the Black male youth increased very significantly between 2019 and 2020, and it not only maintained that increase, but further increased into 2021, which is concerning. Next slide, please. Here we are able to aggregate data over a longer time period, and in doing so, we're able to show some of the information that we had to censor in the prior slide. So here, what's important to note is broken down by sex, but when we're able to merge the data, able to show it to you, we see this very alarmingly. Next slide, please. And I think this is the last data slide. And what I want to point out here, these are two colors that are very similar to each other. There's like a red and a lighter red. But to clue you in, each of these, the female youth are on top. And so this is broken down by ethnicity. Females have an elevated rate of self-harm. The big concern here is between 2020 and 2021, for every race and ethnicity group, there was an increase in female self-harm. So you could see that growth in 2020 to 2021. Next slide, please. Thank you. Oh, I should introduce Darcy. We'll take it from here. Thank you, Darcy.
Thank you so much, Jonah. Appreciate that. Hello, all. My name is Darcy Pickens. I'm with the Office of Suicide Prevention, and one of my main projects is the Never a Bother Youth Suicide Prevention and Media Campaign. Next slide, please. So real quickly, the structure of this campaign, it was co-created with youth from the ground up. That's one really unique component of it. We've partnered with 33 local funded grantees for this project. The media portion of the project is in 46 counties throughout the state, and then digital statewide. So those 46 counties have physical media present, but we are largely digital throughout the state. Also have a comprehensive project evaluation component. And the campaign was really designed to reduce suicide ideation, attempts, and deaths by increasing awareness and utilization of resources, services, and supports among California youth up to age 25 who are disproportionately impacted by suicide. Next slide, please. One of our main resources I highly encourage you to check out is neverabother.org. You can see a preview of that here. We have various community toolkits there on the webpage for education partners, for CBOs. And then there are 3 different sections for coming to the site if you are individually struggling, if you're looking to support someone in your life who is struggling, or if you're looking to support a youth in your care. Next slide, please. So just a little bit more on the toolkits. Many county offices of education throughout the state received physical toolkits. You can see here just kind of the high level purpose of those toolkits. They were designed to support high school based youth suicide prevention efforts. Some schools are using them with a slightly younger population and integrating the materials into existing suicide prevention efforts. but they're designed to prepare students to recognize warning signs of suicide and how they can support themselves or a friend, encourage teachers and school staff to communicate about the subject, and then engage parents and caregivers. And we'll be expanding on that portion here in the fall. Next slide, please. There's also the digital version of our toolkit. So everything that was in the physical toolkit is available online. Plus there's even more. So you can see a list of that here. There are social posts and a lot of youth co-created content on neverabother.org, as well as a lot of activation ideas, how to use what's in the toolkit and how to integrate it into your school programming. Next slide, please. And this is just what I was referring to, a few activation ideas. We can follow up. There are links here in the PDF to the full Education Partner Toolkit guide, but you can also just pull out those specific activation ideas to use on your campus if that's the portion you're interested in. Next slide, please. So 2 videos we wanted to share. I'm not sure that we have time today. If we do and we still want to share them, let me know, but they'll be linked to in the chat, and they're linked to through this PDF. And
let's go ahead and share them, Darcy. Tiff, can you go ahead and get them loaded, please?
And I can go ahead and share my screen if that's helpful.
That's perfect if we can do that. Great, thank you.
Great.
What happens when you call 988? When you call, you'll hear a recording.
You've reached the 988 Suicide and Crisis Lifeline.
It will give you some options. Dial 1 if you're a veteran, 2 for Spanish, 3 if you're LGBTQ+. Otherwise, stay on the line or press 0.
If you select 1, 2, or 3, your call is routed to a national crisis network such as the Veterans Crisis Line or the Trevor Project Lifeline.
If you stay on the line or press 0, your call then gets routed to a 988 Lifeline center based on your area code. For example, if your phone number has a San Diego area code, it might be the San Diego Access and Crisis Line.
The average wait time is less than 1 minute, but wait times can vary and might be longer.
A professional or volunteer will answer and ask you some questions, including your name, age, zip code, and demographic questions.
Answering these questions is 100% optional. You are not required to provide any personal information to receive support.
They will ask you some questions about how you're doing, if you are having thoughts of suicide, and how they can support you, or how they can help you support a friend.
They may phrase these questions like, "What's going on for you today? What prompted you to call today?" And then they'll listen. They'll provide support and share resources.
The goal is for you to feel heard and understood, to help you make it through your crisis, and most importantly, to help you stay safe.
More than 98% of people who reach out to 988 are helped by the crisis counselor or the resources shared during the call, text, or chat, without involvement of emergency services.
If you're not in crisis and it's more of a low point, you might get transferred to a peer support specialist who will help you work through your feelings.
Numerous studies have shown that most people who reach out feel significantly less depressed, less overwhelmed by thoughts of suicide, and more hopeful after speaking to a Lifeline crisis counselor.
And always remember, you are never a bother. There are 3 ways to access support. Call 988, text 988, or chat at 988lifeline.org/chat.
Some people wake up and check their phones.
And we'll show one more here. And this is from the youth perspective about reaching out to 988.
Actually, one of my teachers once mentioned it. He said he called like 98, I think it was 988, and like he was like, "Oh yeah, I called just to like get tips," like, and he talked about how like his experience was great, like motivating other students, kind of like to not be afraid to call.
I myself am not going through anything, but I had a friend that was, and he didn't answer anymore. And I had like a rough estimate about where his location was. And they told me to give them their number if I felt comfortable with that, their name. And so they ended up calling them themselves, and he answered, and they kind of talked him through it a little bit. And I think just at least me knowing that I had that resource was something that was really reassuring for me, because I knew that if I couldn't get there, if I didn't know where he was, like maybe somebody else talking to him would have made a difference. And that's why I decided to know not to hesitate and to just call in case of anything.
I've actually had an instance where I've called myself. It was actually like maybe like a month or so when I found out I was pregnant, because before I got pregnant, I was in like a deep spiral. Like I was drinking all the time, and then I didn't even tell her about my situation. I just like, it was kind of like, it was like a vent. She answered the phone and I was like, and I'm tired of my family and I'm tired of this. And she kind of just sat there and like listened. Like I wasn't really needing feedback. I was just needing somebody to be like, it's going to be okay. And you are okay. And even though you may not feel like you got this, it was something she said. She said like, you may not feel like you have it in the moment, but once that moment passes, you're gonna look back and be like, dang, why was I even feeling that way when I knew I had the support and I had the resources? So if you have nobody who feels like listening, this is the person who is going to listen. And if you feel like you don't have that, why not try? Why not try to have somebody to listen? And I feel like that's honestly what we need sometimes, just for somebody. Nobody's telling you that you're gonna be okay, and hearing it from yourself is different from hearing it from somebody else. Like, no, you got this. Like, life is so unfair, but you can find loopholes to make it fair for yourself, you know?
So I know that 988 is on the back of our students' ID cards at this point, but there's a lot to be said for taking a few minutes to help demystify the process for young people, for everyone, but particularly for young people, and really help 988 be an accessible resource that they're comfortable calling. So encourage you to share those videos with the students and young people in your lives. Only takes a few minutes and can have a big impact. Also helps just kind of open up the conversation around 988 and suicide prevention generally. Never Bother also has a September toolkit available on our website for Suicide Prevention Awareness Month. You can see some of those resources here, including our virtual backgrounds. Much of these materials are shifting to caregiver resources, along with the World Suicide Prevention Day theme of Change the Narrative. So many of them are caregiver focused, how to connect with the youth in their lives around this topic and provide support. We still very much have a strong youth-led and youth kind of conversations component, but we're integrating more and more caregiver materials, and you'll see that reflected within our September toolkit. Next slide, please. Thank you. Just a few things here on kind of how to stay connected. We have a few great resources on how to message about suicide safely and effectively. One of those is from our partners at Youth Creating Change. One of them is from Never a Bother. And they are really excellent resources. The way that we talk about this subject really matters and can have a significant impact on our prevention efforts. So I encourage you to check those out. I've already alluded to all of the resources available on neverabother.org, and neverabother.org/get-involved is where you can find those community resources to activate the campaign in your spaces. And then the contact information for our Never a Bother team is there at the bottom, info@neverabother.org. Next slide, please. And that is it. There's a few links to connect with our listserv, as Sarah mentioned, with our suicide prevention program page and our team here in OSP. So thank you so much for having us.
Thank you so much, Darcy, for being here. I did want to ask Stan one more time to drop the video into the chat. and really using media, meeting kids where they are, really can start the dialogue and open it up. But I am in awe of everyone in this room, not just the presenters, but the people that sat on this webinar for the last 2 hours plus to get as much information, the boots on the grounds, the people doing the work with our students and for our students. As always, thank you for coming, and thank you to our panelists, and please reach out as needed. Have a wonderful, wonderful day. Bye-bye.